The next instruction course, and that is how to predict and reduce post-Lasik ectasia, current concepts and technologies. So basically it is about the post-Lasik ectasia is after the Lasik, and we are trying to comprehensively discuss the causes and the management and the current status of that situation. So I have with me my co-instructor Dr. Rishi Mohan, and then we have Dr. Bhupesh Singh and Dr. Purendra Bhasin. They will be joining us shortly. So my talk is the first, and that is the interpretation of risk factors, the PTA. That has come as a new concept about percentage of tissue ablation, and I've been practicing this percentage of tissue ablation since very early time when I started with the mechanical system, the ALK, automated lamellar keratoplasty, which was a microkeratome where you could vary the thickness of the flap as well as the thickness of the central cut, so to correct a myopia ranging from -2 diopter to -20 diopters. So and we understood that the minimum bed which you should leave is 50% of the total corneal thickness, because we understood that a minimum corneal thickness which is required to keep the cornea stable was at least 50%, and that practice I've been doing for more than 30 years, because we got our ALK system very early in my practice, which is now 37 years old. And I can tell you that even after correcting very high myopia with automated lamellar keratoplasty, where we use a Chiron Technolas system to correct the myopia with the microkeratome, I did not get a single case of ectasia in initial time. So this practice of leaving 50% of the corneal bed is something which I can vouch upon, which I can say that it is the best technique or best practice where you will not have ectasia. Later on, there were issues like what is the corneal, how the corneal ectasia happens in the cases where there was sufficient corneal bed was there, like 300 microns and whatever, and people tried to zero it down to a corneal thickness, residual corneal thickness of, some people said 250 is the minimum, and others said it is 300 microns which is necessary so that there is no ectasia. But I can tell you that 50% of the bed was most important when we thought of corneal ectasia in all these cases. Like a 300 micron was sufficient for a 600 micron cornea, and 250 micron was good for a 500 micron cornea. So that the fundamental thing was that there was a tissue required according to the original thickness of the cornea, and this is what I'm going to talk about. So corneal ectasia after laser in situ keratomiliosis or LASIK is a complication characterized by progressive corneal thinning and bulging, which all of us understand, and it causes significant visual loss. And while most patients who develop post-LASIK corneal ectasia present with identifiable risk factors, especially pre-operative changes on corneal topography or tomography with a Scheimpflug camera, ectasia is present in normal in cases where the preoperative tests were normal and they developed ectasia. So this is a mystery, and that is where all these studies which came into and resulted into this PTA concept has developed into a sure shot prevention of ectasia possibility. First few recognized reports were published by Seiler in 1998. There's this described case reports of patients after LASIK with progression of myopia and rapid progression of central steepening, which they classified as Keratictasia. 50% of cases presented Keratictasia in first year, and 80% in the first 2 years of their undergoing a LASIK procedure. It is more prevalent in males, and younger, higher myopes and thinner corneas are, of course, well known facts. Roberts and Dupp suggested that a biomechanical modification after LASIK is focal in nature, and it went into a situation whereby we realized that biomechanical strengths of keratoconus cornea with brilliant microscopy also found that mechanical loss was focal, primarily concentrated within the area of the cone. So focal reduction in elastic modulus resulted in biomechanical decompensation, initiating a cycle of increased stress, redistribution, and subsequent focal steepening and thinning, and this was actually leading to ectasias. So TEM, or transmission electron microscopy, it showed that there is epithelial hypoplasia and hyperplasia in different areas of ectasia, and there was Bowman membrane breaks and hypocellular stromal scarring, and also in these cases there were thinned residual stromal beds. Artifactually, larger interlamellar clefts within the ectatic regions, so that there was more spacing in the interlamellar fibers, and thinning and loss of rigidity in stress bearing regions of the stroma. Both interlamellar and subsequent interfibrillar slippage contributing to the chronic biomechanical failure in ectasia after LASIK. A nearly identical biomechanical failure is seen in keratoconus. So what we were producing surgically was like whatever is happening in keratoconus in the normal individuals because of their genetic predisposition. So the risk factors were too thin or irregular corneas. I'll stop and welcome Dr. Purendra Bhasin, our co-instructor. Please come on the dais, Dr. Purendra. The larger pupils, higher refractive errors, the unstable vision, which is a major contributing factor, and we realized that we have to wait for vision and power to stabilize for at least 1 year before taking the patient for laser vision correction. Dry eye was another factor. Age, smaller age is a bigger factor in causing ectasias in these patients, and degenerative or active autoimmune disorders were one factor which caused ectasias in all these patients. So the idea from where we got this idea that how to investigate for the ectasia, we realized that we reviewed the retrospective cases, and with review of the retrospective cases, there was diagnostic and surgical skill improvement, screening criteria evolved, and residual stromal bed thickness was given sufficient importance, and topographic abnormalities, where there is a topographic abnormality, there is a possibility of ectasias post-operatively, like thin corneas and thick flaps were another factor which led to the ectasias. So the more important thing was how to continue and do the basic investigations so that we understand the corneal biomechanics and corneal weakness, possibility of weakness was we realized that keratometry, when it is more than 46, or oblique cylinder, astigmatism, a thinner pachymetry. The importance of posterior surface elevation came with this knowledge when we started doing the corneal profile measurement, and inferior to superior corneal power relationship, and posterior best fit square surface was the most posterior best fit sphere That was the factor. When we took all these factors into consideration, then we realized that there are some things which are important, and then we can go ahead and predict as to whether this cornea is weak or not. Additional risk factors was smaller age, asymmetry between two eyes. Like if one eye has a astigmatism at 180 degree and the other has 90 degrees, like with the rule astigmatism and against the rule astigmatism in two eyes, and this mostly this was progressing towards PMD or form first keratoconus. And also in cases where we did enhancement by lifting the flap, thereby reducing the residual stromal bed. That was another factor which took us towards the Actasia at a later point in time. There was this Actasia risk score where the points were given to as to what is the original topography, shape or residual stromal bed, like less than 240 to more than 300, or age 18 or less, and then pachymetry less than 450 microns, and the mean spherical equivalent, like in cases where the power was more than 14 diopters, to anything which was 0, like the power was less than 8 diopters, where the ectasias were seen rarely. These factors, the Actasia risk score, also went in a long way of Government of India giving guidelines as to where the Actasia is possible, and the Lasik guidelines came into picture in the year 2003, where we realized that all these cases, the Actasia is more commonly possible or more commonly seen, and the Ministry of Health gave us a guideline, and that is very important. And you must, all of you must read those guidelines before you undertake to taking patients for LASIK, because those guidelines are there and they are valid for the law, if the case goes in court. The corneal tensile strength is significantly higher in anterior 40%, where we are doing the majority of flap making and laser correction. So laser flap contributes little to corneal tensile strength, and that is why it reduces the tensile strength. And a residual bed of single figure like 250 micron or 300 micron is not a valid figure, because this is not actually a factor which is seen more often, because sometimes a thicker corneal bed is again leads to ectasias in all these cases. So a variable which is 50% of PTA is very important. Percentage of tissue altered plays a significant role in causing post-LASIK ectasia, and it is a change of biomechanical integrity of the cornea which exceeds the threshold required to maintain its curvature. And in theory, this can happen in 3 different scenarios: when the cornea is already prone to developing ectasia, that we can understand by doing different tests, especially Pentacam or Galilei. When a weaker but clinically stable cornea is subjected to surgery without understanding the biomechanics, and relatively normal cornea is weakened by surgery exceeding its safety threshold, where we are removing more tissue than what is acceptable, and the percentage of tissue altered is higher than what it should have been. So the tensile strength of the cornea is not uniform throughout its central thickness, with progressive weakening of the posterior 2/3. This influences the degree of biomechanical impairment after refractive surgery, with flap thickness and ablation depth playing a significant role in postoperative weakness. We have proposed and investigated a new measure, PTA, which is better parameter to describe the postoperative effects on the cornea. This was the study by Santiago and al. And it was published in American Journal of Ophthalmology in 2014, where PTA is the flap thickness and ablation depth divided by central corneal thickness, and it should be more than 50%. So this is a significantly and scientifically validated risk factor, and even in a normal topography, if this PTA is more than 50%, sometimes we see ectasia. PTA especially above 40% and significantly associated with development of ectasia, and this we must take into consideration while doing the correction, as I said about the pupil size and the area of correction, everything. So these are few pentacam pictures where you see that this is despite the fact that it's a very steep cornea, we will not have a ectasia in all these cases. These are all normal cases, but where the K max is 47.7, we must red flag this kind of cornea, and we must be very careful about treating such corneas. And here there is a 4-map composite display: sagittal, curvature, anterior and posterior elevation, and corneal thickness, and where we see the posterior curvature is significantly steeper, and these are the eyes which can lead to ectasias in all these cases. So this kind of eye should not be taken for the laser vision correction, especially the Lasik. And this is a bad display which everybody knows, whosoever is using a pentacam, that posterior float. Here you can see that there is a frank kind of form thrust or keratoconus possibility in this eye, and these should not be at all taken with the. And keratoconus is there in thick cornea also. There is a possibility. Here you can see this, the corneal thickness is sufficiently high, but still there is a possibility of keratoconus in this eye. So only a pachymetry reading is not sufficient. Rest of the factors are also important, and in these cases we should not touch the cornea at all. Thank you very much. So now we go forward, and I'll be inviting Dr. Rishi Mohan. He'll be talking on interpretation of biomechanical analysis, biomechanical analysis. Yeah.
Where do we get those guidelines, Indian government guidelines?
Okay, it's on the Ministry of Health website, and as I said, this was in I think 2003 that we had a controversy regarding ectasia in laser, and I think if you go back, or yeah, that is the best way to get it. Yeah.
So is there any role of measuring, I am here, I am Purendra.
Sorry.
Role of measuring, checking the epithelial thickness in the
Actually, now we have understood that epithelial thickness is thinner in cases where the ectasia is seen in those eyes. So now the mapping of the epithelial thickness is becoming more and more important. And I think if you have any more information, you can pass it on to our audience.
I think we have to check the epithelial thickness also, like ASOCT we should look at, and we will find that normally the anterior segment epithelial thickness is around 50 to 60 microns in all the cases. But in the area where the suspicion of keratoconus is there, there is slightly thickening of the epithelium is there, which compensate with the thinning of the cornea, which is the compensation which occurs naturally. So that also we should look, and that is also an early sign which we can pick up by OCT. So OCT, yeah, more in the in cases where there is a suspicion of keratoconus, and ASOCT should be a part of our complete examination before the Lasik, along with the topography, which includes the posterior float. Topography like pentacam, which includes the posterior float of the cornea, this should be the mandatory examination to rule out any early keratoconus or formafrusty keratoconus. Sir, sorry for interruption, Dr. Rishi.
Right. Thank you very much. It's wonderful to be back, and thanks Dr. Bharti for this wonderful course and inviting me to speak on it. So you've heard a very interesting introduction to this course and how Dr. Bharti has elaborated on the importance of corneal thickness and how much of residual corneal thickness to leave behind when we perform refractive procedures. The question is why these controversies? And these controversies have essentially arisen because topography and thickness are the only two parameters that we have really considered. What we have always omitted is to see what we call the material characteristics of the tissue. And that's the material characteristic that is what I'm going to talk about in this talk on biomechanics. Now, biomechanics has over the last about 15 or 20 years really come more in front, largely on account of studies related to facility of outflow and glaucoma rather than refractive screening. But it has been applied now to refractive screening as well. So I'm going to talk about the importance of corneal biomechanical analysis, and I've been doing this since 2005 when I got my Aura machine. I have no proprietary or financial interest in any of the products. Now, Dr. Bharti has already defined what Keratictasia is, but essentially it's an anterior shift of the cornea with inferior and central steepening. It's got a worsening myopic astigmatism, irregularity, and there are a decrease in the BCVA because of visual symptoms. Just a brief idea of the incidence. If we look at the earlier cases, there were very few refractive surgeries being done worldwide, and so the number of cases reported were not that many. The incidence was 0.66 in Palicaris's study, and later in a study published in 2021, where they did a meta-analysis of many of these articles, they found the following incidences which are largely representative of these procedures, and this includes SMILE. And so you can see that there are about 0.02% is the incidence in PRK. It's about 4.5 times higher in Lasik, and it's 0.01% in SMILE. Still early days because SMILE still hasn't caught on, and we need many, many more numbers to be done worldwide before some real data can come out. So we were talking about the causes, and Dr. Bharti was elaborating on some of these, but largely it's a residual stromal bed following surgery that is thinner than what's expected, and this is either due to an unpredictably thick corneal flap, which can be either mechanical tissue loss, or it's a preoperative pre-existing anomaly or measurement error that may have happened, and these undetected topographic abnormalities can sometimes contribute to the fact that you missed an ectasia. It's the biomechanical properties that I'm going to speak of that is largely the so-called missing link or the X factor, which we have not taken into consideration over these years, and I think as it becomes the mainstay in refractive procedures, we're going to be having much less of ectatic problems. So the concept is that there's a focal weakening in the corneal structure, which starts a chronic cycle of biomechanical decompensation leading to a localized thinning and steepening. And in Lasik, it's a two-hit hypothesis. And this proposes an underlying genetic predisposition coupled with external or environmental factors. And here the external environmental factor is actually the thinning that we have now induced by the Lasik. And it's the changes in curvature, elevation, and thickness that occur due to these secondary events makes the primary abnormality related to the direct biomechanical weakening in the corneal stroma much worse. So the ectasia development occurs due to a chronic corneal biomechanical decompensation of the weakness, and this results in the stromal thinning and corneal protrusion. So 3D tomography has been a significant advancement as compared to the older keratographic or placido-based technologies. But these screening tests for ectasia have always been limited to corneal shape assessment without really looking at clinical biomechanical assessment, which has only been possible since these machines have now come out. So in the preoperative evaluation, it's important to detect the high-risk individuals who may experience corneal ectasia after Lasik from the patients who can undergo the procedure safely, because this complication can occur in patients with or without any pre-existing clinical evidence of formiferous keratoconus. So we do need to understand very basically what biomechanics is. And if you can imagine a shock absorber, and in a shock absorber in a car, there are two components to how the shock is absorbed in the car. There is a spring, and there is a canister which contains a fluid or a gas. And it is the combination of these two that gives us the protection. So the cornea pretty much follows a viscoelastic pattern, and it reacts to strain, or when there is deformation and there is a force that is applied, the amount of bend or compression that you will get in a tissue in the coil spring part of this shock absorber is independent of the length of time for which you apply it. or the rate at which the force is applied. So if you compress a spring, it doesn't matter how quickly you compress it, and it doesn't matter for how long you compress it. When you release it, it's going to come back. However, the shock absorbing or the viscous damping effect is completely different. The faster you apply the force, the more viscosity is going to resist that happening. And this resistance depends on the speed at which the force is applied. And it's a combination of this that provides the cornea its unique viscoelastic properties. So Goldman tonometers, essentially, are tonometers that reach a static state. So they compress the cornea till you get applanation. And in that static state, they take certain readings. Whereas these newer instruments actually look at the dynamism of that movement. So when they actually hit the cornea, they actually see the cornea going in, they reach flattening, but they don't stop. They continue till the cornea becomes concave, and then they stop so that the cornea becomes again flat, and then again returns to its original convexity. And in fact, this process of rapid dynamic movement creates a little bit of a flutter, which it also picks up. And then it uses all this data to tell us about corneal biomechanics. And it is this dynamic measurement that allows the possibility of capturing useful biomechanical data. Now, thickness-based assessments, which is what we were talking about a little earlier with PTA and all that, is that thickness is not resistance. So if one has to look at the strength, one has to look at the material characteristics. So you have a 2 millimeter thick piece of pine wood, and you can bend it. And if you have a 2 millimeter thick piece of oak wood, you can't bend it, but it's 2 millimeters. So the point is, when a force deforms these tissues, how much actual deformation do you get? And that's biomechanics. It's virtually impossible to actually check biomechanics in vivo. In vitro, it's possible. You can take tissues and do, Young's elastic modulus and all that. But in vivo, it's very, very difficult. So refractive surgeons have tried to minimize the potential for ectasia by essentially leaving a minimal thickness of cornea in place, which is good for the large part and on average, but is not entirely satisfactory because biomechanical properties of the corneal tissue for each patient are unknown, and thickness is not strength. So there may be soft corneas, which may require a larger residual corneal thickness than normal corneas, and there may be hard corneas, which may be able to tolerate more aggressive ablations safely. And I recall a patient that I did, he had 22 diopters of myopia. And I told him, you'll have some residual myopia left, and I did 18 diopters of ablation. This is going back to 1995, I think it was when we started. Patient's fine. He's got 180 microns of residual corneal bed, which in today's day and age would be criminal. So at time when there were no guidelines, there were no biomechanics, we only had corneal topographies, Lasik had come in, and this is how it was being done. So even though we reduced the zone size and did everything else to try and reduce the amount of ablation, that is a matter of fact. And I'm sure people who started Lasik going back into the mid-90s will all have anecdotal experiences of patients who we did with high double digits of myopia ablations and got away with it. Luck. So here's the scene. So you look at the pre-Lasik and the post-Lasik scenario of what we call CH. CH is corneal hysteresis, and I'll just talk about it in a minute. And you'll see this average pre-op band of Lasik on the top there, and in the blue dots are all these post-op Lasik bands. So you know you've created thinning. So when you create thinning, you will lead to some loss in resistance. But you notice this one patient whose pre-Lasik CH is lower than the population average post-Lasik CH. This is the one you need to worry about because he's the one who's going to get ectatic. So, like I was saying, if you look at the map at the bottom, you can see that the air puff is hitting the cornea, and then there is a state of applanation, and then there's a state of corneal concavity, and then there's a state of applanation as the air puff goes away. And again, the patient comes back to its normal convexity. And this is what happens to the signal peak. So you get a signal peak when the applanation happens going in 1, which is applanation 1. And then when there's the out signal, when the applanation again happens, that is called the out signal or applanation pressure 2. And it's always different. And the difference between applanation going in and applanation coming out is what we call the corneal hysteresis. And this is critical to our approach. So in a normal patient, this is the ORA, of course, you will find that you have these two peaks which are very similar. You have the two pressures which are very similar. There is a good match between the signal quality and the signal amplitude as well. And the raw signal is fairly smooth. The baseline signal is flat and nearly the same amplitude on both sides. However, as one gets into keratoconus, you can find that the amplitude has got blunted. There are now these little spikes that have come. There is a raw signal that has become much more bouncy and become noisy as well. So these are indicators of a flutter, if you understand what I mean. If you have a keratoconic cornea, if you're familiar with keratoconus and keratoconus cornea, they're relatively softer and they're floppy. So you imagine hitting it with an air puff. It's going to do this. And that's what this machine picks up. So these noisy signals, of course, cause less reliability. Now in subclinical keratoconus, again, you find this odd looking lower amplitude peaks with a bounce and with IOP-CC higher than the IOP-G and noisier signals, but cleaner than the advanced keratoconus and more repeatable. Now you see the severe keratoconus signal. The severe keratoconus signal means that this patient just applanates the moment the air puff hits it, because there is hardly any resistance in this cornea and there is hardly any spike that one can see at all. So this is all indicators of very, very poor signal amplitude. And here there is, don't look at those values in the box, because with this kind of a signal, there is no question that this is keratoconus. In Actasia, again, these signals will match those of keratoconus with a lot of bounce, very low amplitudes and messy signals. And these signatures of the cornea are like diagnostic signatures at least with this machine. We can use these classification of corneal pathologies as well. So if one looks at thickness and one looks at, say, a normal population, which is there in brown, you can see their corneal hysteresis values. You see the keratoconus, they are all thin corneas. They are skewed to the left. So they have poor corneal hysteresis, but these are thin corneas. On the other hand, look at Fuchs dystrophies. Fuchs dystrophies are all thick corneas. They have 550, 600, 650 corneas, but they still have a low hysteresis. So if you just measure the thickness with a pachymeter or with any other device, you can say, this patient has a 600 cornea. He may actually be having a little bit of endothelial dysfunction, but you put him on the hysteresis value on the machine, and you'll come up with a value of 6.5 or 7. And that will tell you that this thickness is not genuine. So these are the other values that it comes in. It gives you a keratoconus match index, where again it uses this signal profile to tell us that there's an 89% chance that this is a normal cornea. This one has a 55% chance that it's a suspect, and only a 34% chance that this is a normal cornea. And some case reports from my own experience where there's patients with fairly normal looking case, a little bit touching just 47. Cornea thickness was a little on the lower side, but terrible hysteresis and corneal resistance factors, and the KMIs were all in the 0.5 range, an absolute no-no to do any form of refractive procedure. Patient number 2, nothing unusual on the case. The Pathfinder topography was also normal, very good corneal thicknesses. Look at that, 550 almost. But look at these CH values, again 9.8, 7.5. So this is a subclinical keratoconus that if you ablate, you're bound to get into trouble. This is the newest device. The Aura, as it existed, is now no longer in the market. They have gone off into glaucoma as their main area, and they're not doing as much of refractive work anymore. But the Corvus ST has very nicely plugged in the gap. It uses a Scheimpflug camera to detect the deformation created by the air puff, and it measures the IOP, the corneal thickness, and the deformation response, and then determines the IOP, which is uninfluenced by any biomechanical property by using the algorithms. It's also very useful for screening for corneal ectasia. And now the manufacturers have clubbed this with the Pentacam to create a new set of indices, which I'm just going to talk about. So the Corvus ST creates a biomechanically corrected IOP. So it gives you, just like the Aura, it gives you an IOP that would match with the Goldman value in which it is not looking at corneal thickness or biomechanical abnormalities, the Goldman doesn't know whether this cornea is abnormal or not. It will just take a value based on the spring force and give you a number. But this machine is smarter. So it will tell you that value also, and it will give you a value which it compensates for the corneal biomechanical change. So this is called the biomechanically corrected IOP. In the case of the ORA, they call it IOP-CC. CC stands for compensated for cornea. And then there's the Corvus biomechanical index, where again it uses the same data to assess what the biomechanics of that cornea are. And then it combines this with the pentacam values. So now you have topography and Scheimflug of the anterior and the posterior float. You have the Bellin-Ambrosio display, and you have biomechanics fed into one system. And they have combined these two to give you by far the best aspect as far as screening for these patients are concerned. So here's a patient. I don't have a Corvus ST, so I am thankful to Dr. Hemlata of the Center for Sight for providing me this. So this is a patient with a 5.5 diopters of myopia. Normal case, corneal thickness is on the lower side, but it's still around 500. The initial plan was to do a FEM to LASIK, but then you look at this value here at the bottom, what we call the TBI, or the tomographic biomechanical index, and you find it is very high. If you look at the Bellin-Ambrosio display by itself, it's not that bad. Both the CTSP and the PTI changes are not outside the range. If one looks at purely biomechanical factors, again, they are not outside range. But when you put them together, you find that you have a patient who would not be a good candidate. So that was converted from a flap-based procedure to a surface ablation. The patient was very, very keen, and coupled with what we call a CXLs to help protect the, prevent the ectasia. So, to summarize, mild ectatic cases typically are at very high risk for iatrogenic progressive ectasia if an additional biomechanical weakening is induced. Corneal topography and tomography have increased their ability to identify these ectatic candidates earlier. Direct clinical biochemical measurement is recognized as paramount for augmenting the specificity and sensitivity for identifying these cases with mild disease and for characterizing the susceptibility for ectasia progression. So corneal biomechanics testing with the availability of these newer equipments allow in vivo measurements of corneal biomechanics and is becoming a key evaluation in ectasia detection and filling the missing link in our screening for high-risk refractive surgery cases. So thank you very much, and be very happy to take any questions if there are.
Yeah, so if you have any questions on the first two talks, you're welcome to ask them. Otherwise, we'll go forward, and Dr. Purendra will take his talk on overview of the Keratictasia causes and legal issues in our country.
Thank you, Dr. Bharti, for including me in your course and regarding this post LASIK ectasia, which is one of the most important thing which we have to look into, and we should avoid this. Dr. Bhupesh is here, so would like to continue, or huh? I think that will make the sequence. It's a topography, I think, to go through. Dr. Bhupesh will be taking. So I will wait. In the meantime, if you have any questions, faculty is there till the time they are making the laptop ready. How many have seen ectasia post-operatively in your practice? All of you have seen the cases of ectasia. Very few. It's a rare complication which does occur, but have you come across and diagnosed it? So the important thing is early diagnosis. What I feel is and prevention is what this course is at, to look at the early signs and not to proceed, and if at all, then we should do CXL along with. That is what is the message.
So we are primarily trying to prevent
Prevent it,
not
yeah.
to treat. So this is not the course.
No,
of-
but in any case, if it is that we
what
have to inform.
what we should emphasize is as to what kind of investigations we should do, and what kind of cases we need to reject before we go forward and do a laser-based
Correct.
Lasik or flap-based surgery, because there are certain factors which we have come to understand are going to cause ectasias or so. What I feel is that the first thing about this whole thing will be that you must investigate the cases thoroughly. Before pre-operative workup should be very thorough, and we should not imagine that a corneal thickness or a corneal curvature, only these two factors or these two investigations will be sufficient to in our armamentarium to give us an idea that okay, this is not the case which should be taken, because as I have shown, there are thick corneas with bad posterior float, and thin corneas where you can go ahead and do LASIK for whatever power is can be corrected and without any issues. Like for LASIK, the minimum corneal thickness which is allowed, or maybe which is 490 micron, is the minimum corneal thickness prescribed by Government of India for conducting a laser vision correction LASIK surgery, flap-based laser surgery. When these guidelines were made, there was no femtosecond laser. So we assumed that in all those cases we will be doing a thicker flap. Of course, this will be taken up by Dr. Purendra Bhasin, but I am saying that we should not think about doing only the corneal thickness and the corneal curvature as two primary investigations or tests to continue and go ahead with the laser vision correction, because with the posterior float coming into picture, the epithelial thickness, like Purendra mentioned when I was taking the talk, the epithelial thickness, which is again an indicator of corneal thickness, because ultimately the corneal thickness totally, sometimes when the cornea is thin, the epithelium compensates and the corneal thickness becomes higher because there is a epithelial hyperplasia at that point. So those factors are very, very important. But since the slides are ready, I will request Dr. Bhupesh to talk about his first talk, which will be interpretation of corneal imaging, especially the Scheimpflug camera and pentacam.
Good evening, all the attendees and respected chairpersons. So I'll be presenting my talk on interpretation of corneal imaging. I have no financial disclosures in any of the machines that I'll be talking about. So corneal topography is an essential component of refractive screening, and the main objective of doing corneal topography is to detect corneas with ectatic disorders and detect corneas at risk for ectasia. So in last 3-4 decades, we have seen various machines that are coming in practice, from OpScan to Pentacam to Galilei, Cirrus, and all have some or other advantage or some or other limitations. Although the true predecessor of topography is keratometers that we have all have practiced in our medical colleges or in our practice also, these Bosch and Lomb keratometers and Jewel Schwartz keratometers. But again, this is a primitive machine, and this also had some limitations, like it gives the values in 3 millimeter ring and just 4 data points, and it is totally operator dependent. So chances of getting something wrong is high. Then came the keratoscopy, and in the keratoscopy, the light is projected on the cornea and the rings are drawn. You can see in this picture the inferior steepening represented by the crowding of Myers. So if the Myers are very close to each other, that means there is a steepening, and if Myers are separated too much from each other, then that means there is a flat area. It also has some advantages, like it's simple, handy, low cost, and quick. although it has some disadvantages like it is a qualitative test, there is no data point, it is subjective, and it also measures just a central cornea, and minor irregularities are also there. So then Elva Gulstrand start capturing the quantitative analysis of the captured image, and he formed the algorithms to obtain data on slope from the Placido disk images. Then came the video keratoscopy. Although this also had some limitations, like the data from peripheral cornea is unreliable. In this machine, the elevation data is not true, it's derived data. It does not apply to irregular corneas, and inability to image the posterior surface of the cornea is not possible with this machine. Thank you. So coming to the current generation of topographers, it can be Placido projection-based topographers or elevation-based topographers. Projection-based topographers are not used nowadays. Everyone has shifted to elevation-based topographers. Again, in the elevation-based topography, it can be slit scan-based topography, Scheimpflug-based topography, or high-resolution ASOCTs. Like in slit scan, OpScan 1 and 2 are there. In Scheimpflug, Pentacam, Galilei, or Ceres. In high-resolution ASOCT, Visante, Omni is there. Talking about OpScan combines two technologies. It has a calibrated video with a scanning slit beam system along with advanced Placido disk system. So image acquisition is like this in OpScan. And if you talk about the data point which it measures around 9,600 data points. It is also non-invasive measurement of data points. And then based on these data points, it constructs mathematical representation of true topographical surface. So from derived, we have shifted to true surface. So this is very important concept to understand the best fit sphere. So for the cornea reference surface, typically a sphere is constructed by fitting the reference surface as close as possible to the data surface, and a best fit minimizes the square difference, always a positive number, between the two surfaces, but only within the spherical region that is known as best fit zone. So all the topography is based on this best fit zone. This is a very common photograph we all have seen. The reason for showing this photograph here is then that you can see all the plain areas in the world are shown by green, all the water bodies are shown by blue, and all the steep mountains are shown by red or maroon. So this similar concept has been used in Cornell topography, which is again a color based. So this scale that is always there in all the scans from any machine. This scale is called Cleist-Wilson scale, and it ranges from 28 to 65.5 diopters. The interval between two colors is very important. It should be 1.5 diopters. If you reduce this interval, there will be a lot of colors on the topography, and anything to interpret is very difficult. So coming to the maps of topography, it can be a curvature map, elevation map, and pachymetry map. These are the very important maps to understand. So curvature map generates from the curvature data, that is Placido disk. It can be either axial or tangential. Again, it is represented by color-coded scales. So this is a chord map from OpScan. We are not using OpScan right now. In our college days, we used to study this. So in OpScan, what OpScan do, it divides the cornea in two zones, from 3 mm zone and 5 mm zone, and then you have to see the irregularity in these two zones. And if it is more than 1.5 in 3 mm zone and more than 2.5 in 5 mm zone, then those cases are suspicious. Again, in the bottom, we get the wide to wide diameters and thinnest pachy, AC depth, and angle kappa. So coming to the gold standard of Cornell topography nowadays, that is Pentacam. So Pentacam is a rotating Scheimpflug camera which measures Scheimpflug images of the entire eye segment. In conventional cameras, the object, that is film plane, lens plane, and subject plane, all are parallel to each other. Whereas in Scheimpflug cameras, these planes are oriented at an angle to each other, and it intersects at a point called Scheimpflug line or intersection. The advantage of this system over conventional photography of the eye is that images along the optical axis of the eye can be assessed. And if you talk about the data point measures, it measures 25,000 data points, from 9,600 to shifted to 25,000 in Pentacam. The key advantage of rotating imaging process is it is precise measurement of central cornea. Correction of eye movement is possible with the machine. The fixation is very easy for the patient and it's a very quick procedure, just take 2 to 3 seconds. So if we compare OpScan with the Pentacam, OpScan was less accurate in imaging anterior surface of the cornea. Pentacam is accurate. Poor accuracy in imaging the posterior surface of the cornea, or sometimes it's not possible also. Whereas in Pentacam, posterior cornea can be imaged very nicely. Inaccuracy in thin cornea was there in OpScan, whereas it's excellent accuracy in thin cornea in Pentacam. And it is a gold standard nowadays. So coming to the reading of maps. So how to proceed there? So it gives so many maps that which one to read, which one to not to look. So first of all, we have to look the anterior elevation first. After seeing the anterior elevation, then see the posterior elevation. After seeing these two elevation map, we have to go to Pachymetry Map and thickness distribution from center to periphery. If you find anything wrong in these three maps, try to correlate between posterior or anterior elevation with Pachymetry Map, whether the thinnest point of pachymetry is same with the elevation, then that will be suspicious cases. After these three, we have to look at the symmetry of both the eyes, how the distribution is there, if superior inferior symmetry is more or less, and if two eyes shows different superior inferior symmetry, then again it is a suspicious case. And we have to look at the curvature in the last. So this is a normal astigmatic cornea. So you can see the K readings is 42 and 46. Although there is no, the superior inferior symmetry is not there. So this is a normal cornea. So we get many patients with high astigmatism. They referred by the ophthalmologist to know that whether they have keratoconus or not because of high K reading or astigmatism. So if you get this kind of map, there is no superior inferior symmetry, then that is a normal cornea. Topography in keratoconus is the most important thing. So it gives many things, like I talked about anterior elevation, posterior elevation, pachymetry. So if you see this map, the pachymetry is 547 at this point, that is thinnest point, and at the same point the elevation is maximum 50, and at the same point you can see elevation front, elevation back. So all four are correlating, then there is no doubt this is a confirmed case of keratoconus. This is another map of post-Lasik ectasia. So normally after Lasik surgery there is a central flattening and peripheral steepening. But in case you can see there is central steepening shown by the red color and peripheral steepening shown by the blue color, just opposite the Lasik. So it confirms that ectasia is taking place. This is another case of post-Lasik ectasia. You can see central steepening with peripheral flattening. So this is the case after surgery. This is a case after Lasik, but there is no post-Lasik ectasia. There is a well-centered ablation, central flattening, and mid-peripheral steepening, which has to be there in post-operative Lasik patients. So after elevation maps, coming to the Pachymetry Map. Pachymetry Map is the most important points are displayed in values and locations. So these give three important parameters: thickness in the pupil center, thickness in the apex, and thinnest location. The preoperative planning for corneal refractive surgery, to know the pachymetry is very important, and for keratoconus detection and quantification, pachymetry is again important factor. So this is a global pachymetry map. You can see it's showing the pachymetry in different zone, and it is increasing from center to periphery. And this map is especially useful for if you're planning intacs, because if you plan to put the intacs in 6 millimeter or 7 millimeter zone, you know at what thickness you're going to put the intacs ring. So this global pachymetry map is especially for the intacs planning. Coming to the Ambrosia enhanced ectasia display, this is a new feature in Pentacam. The original display Ambrosia enhanced ectasia display software showed both anterior and posterior elevation data relative to standard best fit sphere calculated at a fixed optical zone of 8 millimeter. The second component of Ambrosia enhanced ectasia display is comprehensive pachymetry evaluation. I'll be talking one by one. First is the corneal thickness map. So these two maps are the Pachymetry Progression Map. First is the corneal thickness spatial profile, CTSP. So the first one, this graph represents the average progression of the corneal thickness from thinnest point to the corneal periphery. The graph is plotted using red dots, you can see here. And this red line should fall between these two black lines, at least up to 6 millimeter. If there is sudden change before 6 millimeter, then either biomechanics is poor, or it can be a case of post-Lasik ectasia, or something is wrong in the progression. Other thing is percentage thickness increase. There is PTI. This graph represents the percentage plot of above graph. Any sudden slope or rise within the 6 millimeter zone is again considered abnormal. So these are some of the values that are important. Average Pachymetry Progression Index of less than 0.5 is normal, is less. If less than 1.2 is normal, and if it is more than 1.2, it is ectasia. And the shapes of the curves of thickness profile and percentage of thickness increase give additional information. Like see this map, just see the progression, this red line, which is going very in a normal track. There is no abnormal jump up or down. So this is a normal progression of pachymetry from center to periphery. And just see this cornea after Lasik surgery. You can see this also, central steepening. Other factor, at 4 millimeter only, it's going down the normal path. So it gives additional information in post-Lasik ectasia cases. And this is again a map of post-Lasik ectasia. You can see it is not following any track. If the progression map is haywire, then something is wrong with the pachymetry or the biomechanics. Coming to the last part, the new display report gives 5 differential parameters: change in anterior elevation from standard to enhanced reference surface, change in posterior elevation, corneal thickness at the thinnest point displacement, that means its distance from the pupil center. Further the thinnest point from pupil center, more chances of getting keratoconus. And then pachymetry progression. So each of these values is shown at the bottom of the bad scan, Ambrosia display scan report, giving the standard deviation from the normal population mean for that individual parameter. These numbers are color coded to turn yellow when it is more than 1.6 standard deviation, and red when it's more than 2.6 from the mean, and white when it is less than 1.6. So these values are important, and we should remember these values. The final parameter D represent an overall reading of all these 5 parameters, and it is calculated by regression analysis, which the software does. So these are the maps in the bad scan. First is a elevation front and second is elevation back map. So how to interpret them? The standard elevation map, the first 2 elevation maps placed side by side display the baseline relative elevation of cornea of the best fit sphere. And second is the exclusion elevation map. In this map, both anterior and posterior of best fit sphere is calculated using all the raw elevation data located outside 4 millimeter. So first one is the center best in the best fit area zone, and second one is the outside 4 millimeter circle from the thinnest point of the cornea. The location of the exclusion zone is indicated by 4 millimeter circle, and you cannot change the circle position. So coming to the third or the most important part, that is difference elevation map, that you have to definitely look. If it is showing any red signal, then there is no for any surgery. So the bottom 2 maps are different maps. They show the relative change in elevation going from a standard to exclusion. The bottom maps are based on 3 colors, green, yellow and red again. So the green, if it is 6 micron on the front surface and 8 micron on the back surface of the cornea. The yellow, if it is 6 and 12 on the front and 8 and 20 on the back, then it is suspicious. And the red represent areas where elevation difference between the 2 maps is 12 micron anteriorly and 20 micron posteriorly. So this is a complete bad scan, and you can see this posterior elevation. There is a problem in the difference map, although the pachymetry progression is normal. You see this value is yellow, so it's a suspicious, but finally the D value is much in a normal range. So you can do surgery in this case, there is no problem. So again, a map of normal cornea, everything is normal, green, both difference maps are green, and again D value is less than 1.6. In this map, both the difference map showed yellow, so suspicious range, but this D value is 3.23, which is worse. So we should not touch these cases. So finally, these are some of the parameters that we should know, and if find any of these things, we should be suspicious and take action accordingly. Like if the K max is 48.7, the difference is more than 1 diopter, and in phase steepening of more than 1.5 diopters, superior steepening of more than 2.5 diopters, Q value of less than -1. Coming to the Pachymetry Map, if the CCT is less than 470 with normal topography, still you have to be suspicious. CCT less than 500 with abnormal topography, again you have to be suspicious. And then anti-elevation of more than 12 micron and post-elevation of more than 15 micron. So these are the corneas at risk. So we have to be very suspicious and careful before planning any surgery. So in conclusion, interpretation should always be in conjunction with clinical scenario, and we should not try to misinterpret the colors. Thank you. Next up.
So if we have any questions regarding the topography and Scheimpflug maps, which are very important investigations, please go forward and ask them. So we'll continue with Dr. Purendra Bhasin. He'll be talking on overview of the whole session till now, and also the legal issues which are prevalent in our country. And Purendra is practicing in Gwalior and is a prolific refractive and cataract surgeon, and has been our instructor for last 20 years or more, I'm sure.
Not in this course, or in various courses.
Many courses
In many
we are doing
courses,
together. Scleral fixation IOLs and the ICLs and normal IOL cases.
Thank you, Dr. Bharti, and for giving me this opportunity. I just wanted to have regarding topography. This is a recent or current ABCD scoring system which comes in the new Pentacam by the Bell and Ambrosia, and this is superior index, and it takes into consideration, apart from anterior posterior corneal curvature, and this includes the corneal curvature 3 millimeter in 3 millimeter radius around the thinnest pachy, and that is the good part. Otherwise, this previous one was taking into consideration the around the apex of the cornea, and this is at the 3 millimeter radius from the thinnest cornea. So anterior, posterior, A stands for anterior corneal curvature, B stands for posterior corneal curvature, C stands for the thickness of the cornea, and D is the change in the refraction, because up till now we have now not included refraction, because change in power in last 6 months, 1 year, and that also is important, and more in the form of cylindrical power. If there is any change, so we should suspect that there is a. So these are all early things which has to be included into by suspecting the keratoconus or chances of ectasia. So overview and legal issues. So post-Lasik ectasia is a known risk factor and a rare but serious complication of laser vision correction. There occurs progressive steepening and thinning of the cornea after corneal refractive surgery. It can occur following Lasik, even surface ablation, smile procedure, RK, which is obsolete now, or astigmatic keratotomy, which is also obsolete now. So in any form of corneal based surgery, this can occur. The hypothesis is that the corneal, which has been fairly enough dealt by my previous speaker, because it's an overview. So corneal refractive surgeries disrupt and thereby alter the structural integrity of the cornea. Lasik reduces corneal structural integrity both by reducing the overall available load-bearing tissue, because we are making the cornea thin, and by shifting the load-bearing responsibility to the structurally weaker posterior corneal stroma. So we all know that the posterior corneal stroma, the lamellae are sparsely arranged as compared to the anterior corneal stroma. So that is, we are shifting the load-bearing responsibility to the posterior part of the posterior weaker part of the corneal stroma. It was first reported by Theo Seiler in 1998 in the case of a formafrusty keratoconus. In majority of the cases, it occurs within 1 year of surgery. In one series, it has been reported late as 6 to 11 years after the surgery. I have seen case as early as one month after the surgery. I have seen case in post hyperopic laser correction. So that is there. The importance of residual stromal bed thickness is cannot be undermined, because biomechanical studies have reinforced the importance of residual stromal bed thickness after the Lasik. Both stress strain analysis and cohesive tensile strength analysis indicate that corneal strength is significantly greater in the anterior 40% of the corneal stroma than in the posterior 60%. The corneal flap contributes minimally to the tensile strength of the cornea. That is another important fact which we all have to keep in mind. After we have created the flap, then the tensile strength of this flap cannot be included into the total strength of the cornea. Thus, LASIK reduces corneal structural integrity both by reducing overall available load-bearing tissue and by shifting the load-bearing responsibility to the structurally weaker posterior corneal stroma. When the complication arises, it does not necessarily means that the surgery was contraindicated or that there has been a violation of a standard of care, that the patient was a poor candidate for surgery. Post-LASIK ectasia is typically a result of abnormal corneal morphology or thickness that has been overlooked prior to the surgery. The various risk factors for Keratictasia are weak biomechanical properties, abnormal topography, keratoconus, formafrusty keratoconus, pellucid marginal degeneration. Younger patients who may be predisposed to keratoconus or formafrusty keratoconus but have not yet had time to develop them, and we have operated upon them early. So there is low preoperative pachymetry and the degree of myopia is very high, so which we have surgically corrected. So severe biomechanical impact from the surgery occurs on the cornea. The high percentage of altered tissue, this PTA, which has been said by Dr. Bharti also, the PTA should be more than a percentage tissue altered should be more than or equal to 40%. So it depends on the initial corneal thickness. If the and Dr. Bharti was suggesting that it should not be more, it should be less than 50% of the thickness of the cornea. If the thickness of the cornea is 600, and we should not ablate more than 50%, like we should not ablate more than 300 micron of the cornea in such cases. So we should be that is what including the flap. We should not exclude the flap. That is what because flap is having, after the flap is created, it doesn't have any value. A low residual stromal bed due to excessive laser ablation for high corrections or multiple retreatments. So residual stromal bed of less than or equal to 250 micron or half of pre-operative thickness, that is a red signal. Thick laser flaps, LASIK flap due to the blade is some problem with the blade or our microkeratom. We have created a 160 micron, 200 micron, and we have taken into consideration that flap thickness of 120 micron. This can lead to problems. Corneal thickness, degree of myopia, and residual stromal bed are therefore interrelated. A small treatment zone causing abnormal focal stress distribution. Some machines you can reduce the size of the ablation optic zone. So in such cases, your stress on the cornea will be at focal point, and which is more and which can lead to the development of Keratictasia. Severe trauma after surgery like aggressive eye rubbing, this also has to be considered, and all these allergic cases we should treat them simultaneously. Retreatment or enhancement has been reported as one of the cause for Keratictasia, and other sources of blunt corneal trauma can also lead to Keratictasia. Most reported cases of ectasia after LASIK had at least one of the risk factors. There have been case reports of ectasia developing in patients even without risk factors after Lasik and surface ablation, or we may not have understood the topography before. That may be the thing. Ectasia can also occur after uncomplicated surgery, even though candidates are appropriately screened. So, what is the incidence? In the earlier days, when the screening modalities was not, technology was not that advanced, with the incidence was 1 in 2,500 cases. With the newer screening technologies like Pentacam and all, it has come down to 1 in 4 to 5,000 cases. And now I think we are very, very cautious. So that has reduced, that is even less, I suppose. There is a Actasia scoring system. I think Dr. Bharti has already spoken over this, and I will go further. Coming to the law and malpractice lawsuit against the cases. So, LASIK surgery lawsuits are approximately 30% of all ophthalmology malpractice claims in the Western world. And in this particular instance, the patient stated that they were not adequately explained the risks involved, alleged that the doctor should not have proceeded with the procedure because the patient had signs of keratoconus. And a prominent New Jersey laser eye surgeon has agreed to settle a medical malpractice lawsuit for $2 million after performing a corrective vision procedure on a man who should have been ruled out due to a pre-existing eye condition, that is LASIK, that is ectasia. The lawsuit alleged that he was not properly screened before undergoing the eye surgery, as he had a condition known as steep corneas, which led to bulging of the corneas known as corneal ectasia in both eyes. So, another judgment which took place in 2011 and in the amount of $45 million was entered, and on June 10, 2009, Manhattan jury returned a verdict against Dr. Naxarli in Devdas versus Naxarli for his medical negligence in having performed LASIK surgery on a patient who was not a good candidate for surgery because of the condition of the cornea. As a result, the evidence showed that Mr. Devdas developed a visually disabling condition post LASIK ectasia. So, this kind of $45 million lawsuit, I mean, it completely ruins the practice and name and everything of a doctor. So, another case in 2011, Dean D. Angelo filed a statement of claim against Michael Duplessis, MD, and Cataract and Laser Eye Institute of America, PC, in the Healthcare Alternative Dispute Resolution Office for the state of Maryland for the negligent performance of LASIK surgery. And at that point, the patient took a second opinion, whereupon he learned that he had the corneal disease ectasia and was not a suitable candidate for LASIK surgery. So liabilities of doctor arising under statutory regulatory conditions in India are, as per existing laws in India, cases for medical negligence of the doctor can be filed under following enactments at the option of patients. A complaint for the deficiency of surgery services can be filed before the Consumer Forum under the Consumer Protection Act 1986. A civil suit for damages can be filed in civil court, and a complaint under section 304A of the Indian Penal Code in criminal code, as per. But this is after the recent Supreme Court guidelines against the for the recent the problems against the doctors in our country. They have mentioned that a committee has to screen the case beforehand, and the police cannot file a case under Indian Penal Code directly. First, the committee will be assessing whether it is a case to be filed. A complaint to the Medical Council of India or the State Medical Council for deregistration of a doctor on account of negligence can be done as per the statutory the laws in India. Several cases have been reported against ophthalmologists, and decisions have been taken by the National Consumer Dispute Redressal Commission. it is reported that 942 cases of medical negligence were decided by the National Consumer Dispute Redressal Commission from 2002 to 2018. Out of these, 30 were related to ophthalmology. A total of 73% of the alleged cases of medical negligence in ophthalmology were proved. So that is a good warning sign for us, and compensation for the cases ranged between 2 lakh to 10 million were awarded. So what I recommend is that there is a informed consent which is suggested by the recommended by the All India Ophthalmic Society, and they have prepared, Dr. Namrata Sharma and the team has prepared. So for each and every disease, and for the LASIK they have prepared it separately, and for SMILE also they have prepared it, for ICL and other things also. And we should take all this and inform the patient beforehand about the pros and cons and the possibilities of anything which can arise in that particular patient. And even though patient give us a written consent, if you are suspecting the chance that there is the cornea is the patient is a poor candidate for the LASIK, you should wait, you should not go ahead. So to summarize, thorough preoperative workup should be done. Strictly follow the guidelines. Explain all pros and cons to the patient. If in doubt, better to wait or do not go for corneal refractive surgery. Take opinion from your experienced colleagues. I just was discussing in this afternoon only that one patient which was suspected having to have a suspected cornea was refused by one center. Another center took it. Patient had developed Actasia. Fortunately, that patient was managed by CXL, and patient didn't go to the court of law, and they were managed, because now we have the system of CXL. Earlier days we were not having this thing, the knowledge of Actasia and the availability of CXL. So early we can detect and we can manage it. So this is how patients, we should always be always suspect of such kind of conditions in the patient, and we should refuse or wait for 6 months or 1 year before going for the surgery. To conclude, if you know the enemy and know yourself, you need not fear the result of 100 battles. If you know yourself but not the enemy, for every victory gained, you will also suffer a defeat. And if you know neither of the enemy nor yourself, you are not seeing the cornea, and you know you are not aware of that the patient has developed Actasia, you will succumb in every battle. This is the by Sun Tzu, The Art of War. Thank you for your patient hearing.
Thank you, Dr. Purendra Bhasin, for wonderful talk. I will give one comment. A LASIK surgeon in my city did his son, and the son developed Actasia.
Oh.
And unfortunately, let us not go ahead with this, because then the entity will be revealed. But the whole system, why this whole talks we were doing about how to predict and prevent Actasia, is actually we wanted to show the importance of investigations and understanding the different maps, floats and reasons where the Actasia can develop. So I am telling about a refractive surgeon doing LASIK. He has a system where he can purchase a machine worth 5 crores and still was not, like I know a person, know a doctor from my medical days, that he used to give steroids left, right and center, and he gave steroids to his son who was suffering from typhoid and had an intestinal perforation. He came to our emergency and unfortunately could not be saved. So these investigations and understanding of possibilities of complications we must understand, and these are the things where sometimes the masterly inactivity is the rule at that point in time. And if you have any questions, we can answer 1 or 2 questions. We still have 2 minutes. Otherwise, I will like to thank the audience who have attended the last course of this day, peacefully, and we could conduct the course because of my co-instructors who were eminent speakers of this country. Thank you all.
Thank you.
Thank you.